All right. So Dr. Whitfield, who's the PD, is attending the annual meeting in Orlando. So I am left behind to kind of hold things down. So it's my privilege to introduce Dr. Arvin Smith, who's one of our first year child and adolescent psychiatry fellows in the program. He will be presenting today on ASD. Dr. Smith completed his general psychiatry residency at the University Hospitals Cleveland and is a graduate of Case Western Reserve University School of Medicine. He earned his undergrad degree from Rutgers, double majoring in math and cell biology and neuroscience. His academic interests include adolescent depression, and he's currently involved in research on biomarkers of depression. He's co-authored multiple peer-reviewed publications and presented his work at regional and national meetings. In his free time, he enjoys cooking Eastern and Southeastern Asian cuisine. So feel free to put in the chat any orders, and I'm sure he'll Uber deliver later in the day to you. So with further ado, I'm going to let Dr. Smith take over and talk on autism spectrum disorders.
Alrighty, so I'm Dr. Smith, Arvin Smith. You can call me Arvin. I'm going to be presenting today on autism spectrum disorder and kind of wanted to talk about today theories like on the pathophysiology, treatments, and tips. Okay, and that'll be like clinical tips. So this is just a general picture of me with some of my information that Dr. Riccardi already went through. And so at first I just wanted to kind of go through our learning objectives for today. So want to be able to, after leaving here, recall what a diagnosis of ASD entails and when and how to refer if suspicious of the disorder. Identify the proposed pathophysiology, common comorbidities, and potential treatments for symptoms of ASD. And then identify 2 to 3 ways to improve communication with ASD patients in whatever setting, clinical, in clinic or in inpatient setting. Okay, so what is autism spectrum disorder? So it's a lifelong neurological and developmental condition. It affects how individuals communicate, interact, behave, and learn. And it's a clinical diagnosis. So there's no blood tests or imaging that we have yet that can really give us a diagnosis. And we call it a spectrum due to the varying levels of disability. Average age of diagnosis is about 5 years old, and males are diagnosed earlier than females on average. This is kind of thought to be due to different gender expectations in play that are like when kids play that are not quite caught as early on in females with that social aspect. Okay, so why talk about ASD? So ASD, it's pretty quite prevalent disease. 1 in 36 children. It's likely an underestimate, thought to be an underestimate because there are diagnostic challenges. In neurology clinics at tertiary care hospitals, this prevalence can be as high as 45%. That's a number that I saw. 37.5% increase since the year 2000 in the past 26 years. So we've had this question whether this is an increase in the diagnosis and awareness versus a true increase due to some kind of environmental or genetic factor. Valid arguments to both sides, but something to think about. So PCH has developmental pediatrics, child psychiatry, and psychology departments with experience diagnosing and working with children that have autism. Community does have far fewer of these resources, so we actually have quite a good system here, but we do lack some things. So we don't have the ABA, we don't have autism-specific case management, we don't have in-home therapy. So we have a lot of things, but we're not perfect, and there are things that could be better. And so ABA is the applied behavior analysis, which is one of the treatments of autism that we'll briefly talk about. And so just to note some important things to know. So that the Division of Developmental Disabilities in Arizona Long-Term Care System, so short, you'll hear this probably DDD and all techs are some of the major funders for a lot of these programs that you can get in the community. And so it's really important to try to get kids that have an autism diagnosis linked with those services. Okay, so some more things. Parents with autistic children, this is like a financial point. They spend $20,122 in annual healthcare spending compared to 2,201 on average for children that do not have autism. So the cost of the system is pretty enormous. ED visits, behavioral interventions, and medical comorbidities elevate these costs, and we'll talk about that. Of course, there's a significant disruption to the patient and family's life. Now it's a spectrum, so that can be definitely vary depending on the child, of course. So further on, there's neurological comorbidities, so seizures, higher rates, anatomical malformations at higher rates than the general population. Unclear causes, and evolving evidence-based treatments that we're working on. Earlier diagnosis is related to a better prognosis. So really want early suspicion by all of us. We can, get people in to be evaluated. Timely diagnosis is very important. And then, we want to get those appropriate services. Like I just mentioned, the DDD and Altex can be, life-changing. So suspecting ASD and making the diagnosis. So now we're going to talk about some of the diagnostic criteria and who diagnoses this. So yeah, first off, who diagnoses autism in Arizona? So pediatricians can here, and it's different state to state. So the EACAZ program is highly recommended to help and it's a course basically that teaches general pediatricians how to diagnose autism, and pediatricians with that course can diagnose. And when we say who diagnoses autism in Arizona, one of the big things that we're looking at is, can we get DDD and Altex services, or is it going to be a recognized diagnosis? Developmental pediatricians are recognized here, child psychologists, as well as child neuropsychologists who have additional training in testing other cognitive domains as well. Child psychiatrists and pediatric neurologists are also able to make the diagnosis. In other states, SLPs can make the diagnosis as well. In Arizona, it's not recognized by DDD or Altex. But that's also important to note that some states do also have speech language therapists who are often on the forefront of seeing these kids. Diagnosis. So it's a clinical diagnosis. We don't need formal tools, but they can be very beneficial, especially in these clinically borderline cases or where less history is available. Think like some DCS kiddos or homeless kids, foster children where we don't have a lot of history or we don't, but the key thing is here, we don't really need necessarily any kind of special scripted testing, which we'll go over. If developmental history and clinical interview history together show that we have social and communication deficits and restricted and repetitive behaviors, we can pretty much make the diagnosis, or if you have the training and experience. Of course, that has to be said, the more experience you have, the better. So DSM-5 does, for the psychiatry side, is kind of our Bible, and we use it for the diagnosis of autism as well. And we provide paperwork for DDD and Altex all the time. So criterion A is the first thing. You need all three of these. So social, emotional, reciprocity, and we'll go through some examples of all of these. Nonverbal communication, so things like eye contact or hand gestures, and developing and maintaining relationships is important. So looking at friendships and social aspects. And then there's the criterion B, which is kind of looking at your restricted, repetitive patterns, the interests, fixed interests and activities. So we see these stereotyped or repetitive behaviors, colloquially known as STIMs. You see the insistence on sameness, difficulty with transitions. You have highly restricted fixated interests. This will be like some things that I'll go over and even show an example. And then you have hyper or hyporeactivity to sensory input. So that like hyperacusis or hypoacusis. And some additional requirements. It needs to be in the early developmental period, so between 0 and 5 years old. And you must cause, and this is like a rough estimate, and it must cause social or emotional impairment. So we need that. That's the key thing for a lot of DSM-5 diagnosis, DSM-5 TR, which is the latest. So examples of criterion A, I have a bunch of these here. So, some things to look at when you're this is kind of just general things that I've seen as a clinician and some of my attendings have seen. So think about someone who can't really read the room. They have pragmatic challenges, so they have trouble with that kind of like understanding idioms or understanding metaphors, difficulty reading own or others' emotions. So people that have a lot of trouble expressing their emotions, or they always even kids with like a kind of flat affect or blunted affect, you kind of want to start thinking about how they have trouble expressing them. A teenager seeing someone crying about a recent loss, and maybe they laugh with joy at receiving the beautiful flowers that they get during the funeral, and maybe that they have trouble processing the emotions. Trouble with greetings, small talk, making really awkward jokes or statements, and lack of transitions in conversation. So using things like however or therefore, or making the transitions can be very choppy. So like think about a child talking about like unicorns, they sharply change to discuss your tie color randomly, then they make a really dry knock knock joke somewhere in between there. That would be something where you'd be like, okay, maybe there's something going on here. So poor eye contacts, is very common. Way too much eye contact can also be something you'll see. So, that we always think I think in the community, people think, autism means that people have poor eye contact, but that's not true. It's not something you see in every child with autism. And it shouldn't be something that makes or breaks an autism diagnosis, but it's something we see. No hand motions or facial expression during time that seemingly should be emotional. That's something to look for. So a child looks to the ground with no facial expression, describing a recent loss of a pet, but they report sadness, and there's just no expression really on their face. And again, this can happen in lots of mental disorders, and even some people just happen to process grief differently. So this is again not a make or break, but something you want to look deeper into. Trouble naturally reading others' gestures, such as like let's say you give a thumbs up or laugh while stating an ironic joke. Like you'll tell like let's say you tell a kid you're really growing into a giant at like a general pediatric appointment and you're laughing, and the 10-year-old autistic boy is very worried that they're turning into a giant. Another thing is looking at some of the social stuff. So if someone says like everybody in the class is Joe's friend, or they have a very specific number of friends, it's a little bit less common. But when you see it like everybody in the class is their friend, or someone that has absolutely no friends, you start to think about what's going on there. Are they actually having, you know, building bonds? And yeah, inability to form best friendships or close friendships. Everything's very superficial or not there at all. Disinterest in others' interests is a social means. So, like, we all have to make some concessions sometimes. So, may completely ignore your statement about your favorite football team and just continue to discuss their history or whatever interest they have. Small talk with some of these kids can be pretty painful, like difficult for both parties without coaching or knowledge. And sometimes you'll see, yeah, like I said, no friendships at all, lack of interest in making friends. And not everyone, a lot of kids with autism really do want to make friends, and it can change through the course of their life, which I've seen. So we talked about kind of stereotypy, so colloquially known as STEM. So these stereotypic movements and vocalizations can be either they're constant, they appear motivated but purposeless, and new ones can appear throughout someone's life. This should be, again, really starkly compared to tics, which are typically more jerky, non-rhythmic movements or vocalizations. They usually start around 5 to 7, and they often have like an urge beforehand, exacerbated by stress or anxiety. Well, stims are thought to be, or stereotypies, more so self-soothing behaviors for autistic children. Again, and they're also like typically rhythmic, prolonged, and they start before 3. So you can start seeing some of them pretty early, and they change with excitement or boredom. Lining up toys in a rigid order and being very upset when they're not can often be an early sign of ASD that you see. And then there's echolalia and echopraxia, which is also kind of non-specific symptom, but so you'll hear them say, "Hi, I'm Tony," 6 times after hearing you say it. That's the echo part of it, and they'll repeat it. The echopraxia is like constantly turning the sink on and off after watching someone else operate a sink, and you'll see like these behaviors. Hand flapping, body rocking are some examples of stereotypies. They can be pretty complex, though, just to go back to that. So, lastly, we're going to talk about the sensory stuff, some examples. So, let's say, like, you see someone like, so extreme distress with minor changes in daily routine. So, that's like the transition part of it. Oh, sorry, this is the routine. So, same food, same sleep time, same outfit, same time to use electronics, same times to defecate or urinate, same toy type. And let's say you switch this on them in any way, shape, or form, it can create like a huge amount of aggression. Transition difficulties we mentioned. So let's say it's new school, and I have a patient recently that is going through a big move, and that caused a huge uptick in behaviors and aggression. So respite care, new caregivers, new providers, these are all things to kind of, you want to keep things the same if you can. And so some more things. So now we're going to go into some of the sensory stuff and the hyperfocus. So first the hyperfocus. So like you'll see them very focused on sometimes like seemingly purposeless, at least to the observer, facts or focus interest basically. So things like train schedules, historical facts, capitals, currency exchange rates, anime characters. You'll see in the sensory part of things, so like seeming ignorance to painful stimuli or hot, cold, kind of the hypoacuity, acusis, and then intense distress to tactile stimuli such as clothing, tags, and food. So a lot of kids will end up with like an orphid diagnosis. A lot of them will not be able to wear any clothes except for athletic wear that doesn't have any tags on it. All of those things would be like, okay, you're suspecting maybe this kid has autism. Difficulty with large crowds, noise, or low high amounts of light is kind of a classic one that the community often thinks of with autism. That's the hyperacusis. And then there's a fascination often with certain smells or tastes. Like I was working at the special needs unit in Aurora, there's a couple kids actually that would kind of chase around certain behavioral texts that were certain cologne, and they're very fixated on smelling that. So sometimes you can use that therapeutically as well if there's certain smells that the kiddos like. So this is just an example of I had another example that Dr. Riccardi and I looked at. I wasn't able to get it scanned in properly, unfortunately, but this is another example that I found online of a kid with autism that basically is just completely memorizing all of these video game characters and their basically some kind of attack move that they have. And so this is something that you'll see, and they'll literally memorize all of them. Of course, you can have a normal kiddo doing things like this, but it'll be pretty excessive. One of our kids basically memorized, all I think it was Delta and United Airlines flights, essentially the actual flight number, and it was very kind of quirky, specific things like that. So I just wanted to talk about intelligence, just because it's something that sometimes is misconstrued. So roughly 10% is the kind of the estimate, have some kind of special talent or savant ability. However, this estimate varies, and it's not actually particularly common, um, which I think is an important thing to think about. So just because a lot of people are like, oh, like all autistic, kids are really, really, really have like some really, really special talent. They can play the piano or they can, dance really well. But it is higher than the general population. So 60 to 70% are in the normal to higher intelligence range, and 30% at least roughly are within the normal, like the lower intelligence range under 80. And just important, yeah, IQ and adaptive functioning have a greater disparity in ASD population, just so we know. So yeah, the 90 essentially I think is one standard deviation below. So just to talk about standardized observation tools, so the ADOS is I think important to talk about. So ADOS 2 is the Autism Diagnostic Observation Schedule. It's flexible, partially scripted interview. There's a play component. You observe the kid and you kind of go through a checklist, and there's very specific tasks to assess for ASD. It's often considered the gold standard. It requires certification and training to really establish reliability for it. So not just anyone can do it. It's often done by our psychologists here. It can take several hours, like 3, 4 hours. 12 months to adults. So there's different modules. I think there's five total for different age groups. And Cars 2 is another one. So there's 15 items on this. It's like relating to people, imitation, emotional response, etc. goes on. And there's all the different kind of things also mentioned in the DSM-5. It's used to some degree. There's also GARS 3, SRS 2, and then some cognitive and adaptive scales. I'm not going to go into detail with all of these. I just want you to know that there's a lot of them. But the ADOS 2 is the major one that's used. So these cognitive and adaptive scales are more so to look at function. This is not something that we use to actually diagnose autism. So it's the Stanford Binet or Vinland scales are often used for cognitive abilities or daily living skills, respectively, to provide context of the illness in terms of the functioning. So it's important because, again, like we talked about DDD and alt text being like really important, right? So DDD, again, is kind of for anyone with autism. Alt text is more so for people that have they need to really have functional deficits to get it. So that's why some of those scales can be helpful there. Um, and it can vary in different states. Like some states may require more significant testing than others. A note from a licensed neuropsychologist, ADOS 2 administrator, or child psychiatrist with detailed documentation is sufficient in Arizona. Neuropsych testing, it's more comprehensive than just an ADOS 2, and it's not necessary for diagnosis. So neuropsych testing is like 10 to 12 hours. It's multiple days. It extensively tests your cognition, besides, and looks at a lot of different psychiatric conditions as well. It's very extensive, it's expensive, and sometimes it can be necessary, especially when you're trying to look for other cognitive domains like visuospatial, if you have suspicion there, or suspicion for some kind of learning deficit. But it's not necessary for just the diagnosis of autism. It's usually reserved for use when there's other things that we're trying to figure out. Yeah, and so recent research actually showed that a trained developmental pediatrician can actually reach an accurate diagnosis looking at the ADOS 2 in 90% of cases just using their clinical judgment, developmental history alone. So the ADOS 2, which is pretty lengthy, it's not always necessary, but it's very, very helpful. You want to use it especially for like borderline cases, things like that, or or DDD wants you to have more information. They can never know exactly what kind of pushback you can get. So pathophysiology. So there's the heritability argument. So studies are mixed. So heritability is estimated to be between 40 and 90%. There's just a lot of studies, so the range is pretty high, all different kinds of quality. Twin studies most often display 64 to 90%. So a little bit, 40 is a little bit on the low. They compare identical and fraternal twins. The limitations are smaller studies typically. There's not that many twins out there. They're difficult to emulate in the general population despite great genetic control. But for heritability purposes, pretty good. And we have population-based analysis, which have displayed lower numbers, larger data sets, better at detecting environmental triggers. Now with genetics, or the genome studies, we can get more data on genetics to kind of further help with these kind of studies, but the limitations are that it's difficult to control genetics to the degree twin studies can, but that's getting better. Hence, the environmental causes are estimated pretty wide range too, 10 to 60%, but many experts kind of go with the 20%. So what has actually definitively been linked to autism and pregnancy? And definitively is a strong word. I don't know if I really want to use that, but when I say that, I mean experts kind of have come together and said the data suggests this, as well as there being pretty strong, like the correlation being very strong and the studies having very good confounder control. So severe maternal infections and prolonged fevers, air pollution during the third trimester, heavy metal exposure, lead, cadmium. Valproic acid, strong and it's independent of seizures or mental health conditions. It's dose dependent and it's not seen in other anti-epileptics like lamotrigine or levetiracetam. So that's an important thing. So valproic acid, we already know for the neural tube deficits being an issue, but this is just another thing to be careful with those childbearing age women. Elevated prenatal age, maternal obesity, and low birth weight have been associated strongly with autism. Not routine vaccines. There's multiple large-scale studies, especially the MMR vaccine, with thimerosal being kind of the worry that that was causing it. There's no clear data for that. And this big study that kind of people quote with that British fellow was pretty much debunked. And not acetaminophen, I mean, there's some, I won't go too in depth with this. I mean, there's some mechanisms that were proposed for why acetaminophen could potentially lead to an autism phenotype, but there's just a lot of confounders. Most of the studies, first of all, the studies are inconsistent, and then a lot of the studies that are used to make this argument have the confounder of maternal pain, maternal febrile illnesses. It's really hard to actually uh, control for that, just because most women aren't going necessarily to the doctor for every single little cold that they get. You get a lot of most of the retrospective studies have that bias of not being able to get necessarily reliable, like recall bias essentially. It's also a big issue here. And just little pains and aches, I mean, they can be a sign of something more serious. SSRI use versus maternal depression is still in debate. Like, is it the SSRI use or is it the maternal depression? There's a weak correlation in some studies for the SSRI use. So continuing with heritability, we don't have a genetic cause of autism that 100% causes autism. There's 1,000 distinct genetic loci and 100 plus high confidence risk genes that have been identified, though. And there's more in the works, and every year we add to this. So some of those high impact monogenic mutations, they have a strong effect and a very specific syndrome to them. So SHANK3 with Phelan-McDermid is one that's actually really actively being targeted right now with gene therapy studies. We have SCN2A with comorbid epilepsy, CHD8, macrocephaly, GI issues, and I have several other ones here. We know Fragile X cancer with PTN mutation, and then MECP2 is Rett syndrome. They have higher rates of autism. The thing here to keep in mind is really there's a lot of genes, and they have a lot of medical comorbidities. Down here, I have some other genes that have all just been identified in 2026 alone, so we are really adding to this rapidly. So there's the CNVs, these copy number variations, which is kind of like there's several examples I have here. So like we have deletions and duplications. So 16p 11.2 deletion, like 1% of all ASD cases actually have that. And then the 15q 11 to 13 duplications, they also have hypotonia seizures. And we all know DiGeorge syndrome 22q 11.2. ASD and early onset schizophrenia amongst complex medical issues. That is a typo. So common polygenic variants. So this is another thing that's being looked at. So their additive effect, there's no specific mutation or syndrome like the other two things we discussed, and there's weak correlation. So probably heard of the MTHFR, like the folate metabolism gene. High prevalence of that in autism, folate metabolism, no clear established causation though. And then there's CNT-NAP2, which is more linked to like language delays, and it's involved in synaptogenesis. So pathophysiology, it's a work in progress. I'm just going to go through some theories. I'm not going to, just for the sake of time, I'm not going to go too in detail with everything. So leading theories, so we have synaptic pruning and the excitatory inhibitory imbalance, also called the EI imbalance. So other theories like connectivity, synapse functioning, we have cytoskeletal studies. I saw a lot of them at ACAP, our conference for child psychiatry, a lot of the basic science studies looking at tubules, microcilia, and we also have mitochondrial dysfunction is a theory of autism. There's probably facets of all of these given it's a spectrum. So synaptic pruning, so it starts at birth. And just of note, like synaptogenesis is kind of the opposite of pruning. So pruning is like removal of synapses, and synaptogenesis is the building of synapses, which is, something that we all think of as a good thing typically. But pruning is also really important. So it starts at around age 2 to 10 years. It starts at age 2 and it goes to at least 10 years old. But the process is always happening to some degree. But the rapid pruning happens here, and it's very important. in which like 50% of infant synapses are removed. It continues at a slower rate into adulthood, as does synapse formation, and there's a balance. And synaptogenesis also has a rapid period of growth, 0 to 2 years old. And that's the growth of these synapses, the building of synapses between neurons. We have 2,500 connections at birth and 15,000 roughly as a toddler. And it continues into adulthood. Um, it's a use it or lose it kind of mentality here. It's kind of like muscles, but in this case, improper connections can really be an issue. Proper pruning involves, getting rid of unnecessary synapses that aren't used and keeping those vital connections. So you can only imagine what could happen if it, isn't working. Glial cells are implicated. So, people love astrocyte studies. Astrocytes are pretty exciting. They're thought to be involved in here as well as microglia, and that's the immune side of things. Apoptosis is also thought to be impaired. So keep in mind, synaptogenesis and pruning are the removal of synapses. It's the connections between neurons. But apoptosis, the actual death of neurons, is also something that's important in development. So ASD kids were actually found to have 63% more neurons than non-ASD kids in postmortem studies. And some scientists think that maybe like the head size could be related to that. Neurogenesis is typically mostly completed by birth, but again, we talked about um, synaptogenesis part. So neurogenesis is the actual creation of the neurons, and synaptogenesis, we already talked about, does have a rapid period right after birth, like the actual connections between those neurons. So all of these things are important. And so just to kind of go also with glial cells, astrocytes can help, they actually have a juxtacrine and receptor. They actually like bind onto some of these neurons to kind of help with the apoptosis. So that's important to know they're actually implicated in that. So how does this relate to the EI hypothesis, excitatory inhibitory imbalance? So late adolescence, on average, ASD children have 16% reduction, while neurotypical children, like we discussed, typically should have a 50% reduction in these synapses. Because of this, there's a high noise to signal ratio. And what does that really mean? It's kind of, there's too many cooks in the kitchen, essentially. It's linked to high glutamate to GABA ratio. The sensory deficits can be directly linked there, and dysfunctional microglial neuroimmunological activation. So high glutamate, low GABA seems to lead to some neuroinflammation as well. Some other things, so mitochondrial dysfunction, dysfunction in metabolism of microglia, and cells linked to immune dysfunction, thought to be linked to the impaired pruning, and apoptosis as well. mTOR overactivity, so mTOR is an important molecule involved. So like rapamycin, for instance, is an inhibitor of mTOR. It's a pretty famous drug. So it's a cell survival receptor. It's overactive in autism, and it's pro-inflammatory to a degree. And think about like cancer and inflammation. Difficult pruning as well as apoptosis and to be able to kind of take faulty neurons, and typically there's like an autophagy, like a removal of the bad neurons essentially, or the bad synapses. Both of those things are impaired when mTOR is overactive. And think about it like cancer also, like mTOR is overactive often. Ciliated microtubules, so dysfunction is linked to impaired glial cell function, impaired pruning, apoptosis, and there's a lot of basic science studies coming out now showing this dysfunction. A lot of them are also in animal studies. You can argue a lot of the mammals that kind of have similar social behaviors as animals, you can model, like prairie rats, I think, are one that they've been looking at, and they can kind of model what an autistic prairie rat looks like, actually, which is interesting. And they've done studies on cilia and microtubules. So we think that this, we're going to put this all together. So environmental stressors and genetics lead to early neuroimmune dysfunction. We have that leading to impaired pruning and to some degree neuronal apoptosis. Cell metabolism and cytoskeletal structures are implicated. And it's just interesting, like a CVA involving the fusiform face area, cerebellum area, parts of the cerebellum and specific frontal cortex regions can display autism-like phenotypes. And it's just kind of interesting to note that. And this would be like in an adult even. So that it's interesting. It's of note. There is this organic nature of it. Risk of other medical conditions, so like 46 to 84% of some chronic GI symptom constipation, diarrhea, abdominal pain, likely related to both behaviors like holding, just usually a sensory thing, and caprices, and also like some neurological deficits, probably the gut brain hypothesis. And then, sorry, I put this up a little earlier, 20 to 40% having some form of epilepsy. Um, 20 is more conservative, 40 is a little bit more liberal, but it's probably somewhere in between there. And seems to be higher in females, and we already know the intellectually disabled patients have higher rates of epilepsy as well. So that just is an additive factor for an autism plus intellectual disability patient. Sleep disorders, so insomnia, frequent awakening, shorter sleep duration, we see in 50 to 80%. And 32% have some kind of immunological condition. So we know that there's some immune dysfunction in these kids, probably leading to autism as a theory of pathophysiology. So it's an interesting thing to know. And then catatonia. So catatonia is a neuropsychiatric condition with a clinical diagnosis involving basically like muscle stiffness, other neuropsychiatric complaints, waxy flexibility, which is kind of where their arms, when you move their arms up or their legs up and they just stay there. And it's assessed with a scale we call the Bush-Francis scale. I'm not going to go into detail about it, but it is much more, is a higher risk in these kids with autism. Up to 10.4% of them can develop it, which is very high compared to the actual prevalence. So current and emergent treatments. So just to go over some psychiatric comorbidities that we see, so social dysfunction, agitation, self-injury, sleep impairments, anxiety, OCD, obsessive behaviors, just to list some of them. We have no cure or effective treatment for the symptoms of ASD itself. We do have the ability to treat these though. So we talked about applied behavioral analysis, the gold standard directed at an early age, the earlier the better, and reducing problematic behaviors. It utilizes clear antecedent and consequence monitoring, heavy use of positive reinforcement, small rewards, and negative punishment, removing attention, therapeutic ignoring, and it extinguishes target behaviors and encourages pro-social behaviors. And this could be anything like getting rid of agitation and eating, let's say. It can, you want to be very specific in what behavior you're targeting, though. Current treatments, so Risperdal, aripiprazole, so Risperdal is a D2 blocker, 5-HT2A receptor blockers. That's a serotonergic receptor. It's actually the target of magic mushrooms. Fun fact. It blocks that, so you can kind of understand why it would work as an antipsychotic. And Abilify is mostly a D2 partial agonist, also has some 5-HT2A effects, but it increases dopaminergic effects in parts of the brain with low dopamine, and it blocks dopamine in parts of the brain that have too much dopamine. Those just happen to be the two that have been studied the most. They're FDA approved for, I don't have it off the top of my head, but in children and adolescents, I think Risperdal for a little bit earlier age than Abilify is, or aripiprazole is. And it has the most evidence for effectiveness in physical agitation in ASD. These two. So recent large RCT for caripiprazine as well has shown promise. It's a partial D3 agonist, just of note, and higher. So there's other drugs that are being looked at. Higher sensitivity and neuroleptic malignant syndrome and extrapyramidal symptoms than the general population. So you want to use low doses and be careful with these kiddos. Leucovorin can be effective if introduced at an early age for children with specifically cerebral folate deficiency and ASD phenotype, but not in general. It's not a groundbreaking treatment, but there are some studies that say it helps. And it basically is a folate metabolite that skips some of the parts of the enzyme steps, so you get improved bioavailability. And then clonidine, N-acetylcysteine, NAC has lowered self-injurious behavior in studies with patients that have ASD or intellectual disability at high doses. And this is thought to relieve oxidative stress and improve immune function. Propranolol can be used, so there's beta blockers for social anxiety, and clonidine and guanfacine, which are alpha 2 blockers, can help with impulse control and difficulties, as well as like ADHD, which is often comorbid. So emergent treatments, I won't go into great detail about everything, but let's talk about some of them. So intranasal oxytocin, inconsistent, has to be given pretty much close to birth, and it seems to improve bonding and emotional regulation. bumetanide. Bumetanide is our loop diuretic. It has mixed results, or things thought to be resetting GABA signaling in the brain to reduce hyperexcitability and improve facial emotional recognition. Um, Looks like it was the best in 3 to 6 year olds. And AJA001, it's a botanical drug candidate, full spectrum hemp extract containing CBD, and it is in phase 2 trials for irritability, showing some promise. L179 is a tyrosine hydrolysase inhibitor thought to regulate catecholamine dysregulation that's noted in ASD. This is a enzyme that tyrosine hydrolysase, if you remember all the way back in biochem, it turns tyrosine into L-DOPA. Some other ones, JAG201, so that's for SHANK3 mutations. It's a gene therapy, basically replacing the SHANK3. It has to be done with intracerebral injections, ICV injections, and can work in older children too, which is nice from the early studies via loss of, and this would be like the loss of function or deletions. This is for haplosufficiency. Transcranial magnetic stimulations, or TMS, similar to depression treatment. We typically look at the left inferior frontal. We're looking at the left dorsolateral prefrontal cortex. This is typically what we do in depression as well. So that superficial kind of region of the brain, but we're targeting through that the downstream effects in the basically in the lower parts of the brain. So I think some of the parts that we're thinking of are the left inferior frontal gyrus for social cues, a cingulate gyrus, repetitive behaviors thought to be related to that, and the amygdala for emotional responses. So there's also some microbiome related therapies. So AB2004 is currently being studied for brain gut access, and this is thought to, help. Essentially, it's a scavenger. It gets rid of these neuroactive microbial metabolites. So this is the thought that there's some like bad bacteria causing issues for basically immune hyperactivation in some of these kids with autism. It's in early development, and specifically for irritability. So this is a slide. If when you guys get access to this, you can look at all these different treatments. So communication tips, important takeaways. So let's say you see a patient with ASD in your clinic, or that you suspect has ASD. Gather parental guardian history first, or, especially if they're higher functioning, you still want to, introduce yourself and, be really cognizant, just because they may have some social deficits doesn't mean they still, or you want to be autonomous and have a lot of, control over their appointment as well. But gathering the parental guardian history would be really important still, because they may not be able to give you as much. And especially for those nonverbal kids, you want to use like visual tools. So like even printouts, before your clinic appointment that you can get with obtaining or delivering information to a patient with ASD. You can shave off time for a complicated interview, or, all the agitation that may occur if you're like, let's say they're going to be doing some kind of lumbar puncture, or they're going to be inpatient for a while, they're getting some kind of procedure. It can be very hard for kids that have autism with transitions like that. So giving them the expectations ahead of time in an image can actually be very helpful. Let's see. And so this is an example of like a very basic like storyline for kids with autism. So this is for like my morning routine, for instance. They see what they need to do. They can see the pictures. Kids with autism are often they're quite visual. And this gives them exactly, what they're gonna have. So we'll often use these kind of things on the unit for routine with kids that have autism. It helps with, managing expectations. This is a kind of crappy picture, so I apologize, but I just wanted to kind of let you know about this website. So BMC Autism Friendly. The link is here. This has like access to lots of different scenarios that, let's say, a kid with autism could end up in. For instance, this one was like a medical appointment, And so it gives these story. This is actually at Boston Medical. So it kind of gives you a storyline for a kid with autism, paints the visual picture for them. So what can they expect? So seeing a patient with ASD in your clinic. Keep in mind the possibility of that hyperacusis, or hypoacusis. So fidget tools, keeping the room dark, using scents that may be, you want to avoid scents that are gonna be irritating, but if there's some scent that really calms them down and is soothing, I would, maybe you can get that, and have that in your office. Sensory modulations or distractions that allow for less distressing exams. So, you probably want to talk to the parents beforehand to kind of figure out what kind of things would help with that. And, sometimes we'll give the kid their iPad when you're trying to do, get blood draws, things like that. And then all ASD patients should have genetic screening. That's our new policy. It's a long time coming, I think. So inheritable conditions, right, have a higher rate. Medical comorbidities, higher rates. It helps with family planning, research. Um, and I think and one thing I think, and just wanted to mention, like Arrowhead ED, I believe actually has a sensory room for kids that have autism, which or anyone with a mental health condition, but I think specifically for autism can be very helpful to kind of for some kids. Everyone's different, but if they have a high sensitivity to sounds, things like that, it can be helpful, especially when you're going through something medical. Um, so again, let's say you just suspect autism in your clinic with an undiagnosed kid. If you're considering ASD in an undiagnosed patient, so you could place a DEV-PEDS referral for a kid under 5 without, especially without behavioral issues, or child psychiatry, psychology, evaluation for any age with behavioral issues. If wait lists are long, you can definitely place a community referral, and use social work to your advantage here. They're really good. So this is programs and services at Encircle Families. So Encircle Families is a website that can help get patients into group and peer guidance. So this is really great. I send it to most of my patients with newly diagnosed, like all of my patients with newly diagnosed autism, especially the ones that are really having trouble navigating the system. Peer and group support is really, really helpful, and can help them navigate DDD, all techs, the medical system, you name it, and just dealing with having that diagnosis. The Emily Center here is helpful. They have education and pamphlets. It's not necessarily going to help with the navigating DDD and all text, because from patients that I've had, the parents have said that is more helpful for learning about the diagnosis. So if you're trying to get help with DDD and all text applications, I think the peer and the groups can be more helpful there. But the Emily Center is definitely great for getting education about the disorder. So this is my bibliography. It's a lot there. And then there's also all those links from the emergent treatments as well. Then any questions? Again, I'm not an expert in autism by any means, but I can definitely help answer some of those questions if I do have the answer for it. And look it up if not. That's my email too, if anyone thinks of anything or wants any resources that I had.
Thank you, Arvin, for that informative talk. I'm sitting here with Dr. Bacchini. We're kind of like sharing a screen here. I just had a question. What challenges do you anticipate providers are going to face, especially like at PCH and in our state, with some of the recent kind of financial cuts to programs, moving forward in managing their ASD populations?
I think one big thing will be if we see cuts, we're gonna basically they're not going to be able to dole out DDD and Altex as well maybe as they were able to before. So we're going to see a lot of kids that maybe should have ABA at an early age. And I see this sometimes with parents giving up when it's just a very difficult thing to get. And I think we're going to see maybe an uptick in, problematic behaviors that are going to be an issue, and not only psychiatry world, but I mean anywhere in the medical system where, we are trying to get things done, and you'll have like agitation or worsening obsessive symptoms and more ARFID, things like that, that may have been able to be targeted if we had those services in place. And then there's the question, is autism actually increasing in terms of actual prevalence? Is it something that, and we see that, is it because of an actual increase in the actual diagnosis, or is it in the actual uh, people with actual autism are actually the same, we're just catching more of them? Or is there actually an increase in some environmental factor that's driving this, which I think is the current thought process from, RFK and kind of, it's hard to say which one it is, but I think that that's something that could, if there is an increase in autism diagnosis, just overwhelm the system too.
Thanks.
Hi, this is Deanna Raz. I'm one of the developmental pediatricians here. Thank you so much for chatting with us about autism. Can you all hear me?
Yep,
We
I
can
can
hear you.
Okay. Okay, thank you. Something that families kind of ask a lot about, and I'm wondering if you get this too, with regards to ABA. There's a lot out there. ABA, as you mentioned, has been around for some time, and there's certainly some negative feedback from many people about ABA, but also some positive. What's kind of your way to counsel families on what to think about ABA?
Yeah, and I've had some families too with that there's I think some special schools here that have like it's like a kind of watered down version of ABA, like, and I think it's NBT, where they get like some uh facets of ABA, but not quite, like the therapeutic ignoring will be done, things like that, where parents are like feel like their kid is in such distress. And I know that there's a lot of advocates that have autism that are older and really speak out against ABA as a cruel technique. Um, I try to really say that not all of them are equal. Like some ABA, like some of the ABA centers I know are better than others, and in-home ABA providers. I've heard parents tell me that, that have had older kids with autism that have been through the system for a while, that they had one ABA provider who didn't really seem to know what they were doing, and others that were very, very effective. And so, I mean, there is definitely, you know, I think at least my whole standpoint is at least to try it and see um to see if it's something that they're comfortable with. But I do agree that there is a element of it that can be somewhat traumatic to some kids and some parents. I don't want to completely ignore that. So I usually say to at least give it a go. And if you're feeling that it's something that you don't align with, that there are some other options, um, that's kind of my take on it. I don't want to force anyone to do anything, but it does seem to be fairly effective, especially at that young age.
Yeah, I agree. I also, I think that goes to, is the case for any kind of interpersonal therapeutic option, right? Not all of them are going to be a good fit. So there's certainly lots of elements to consider. Thank you.
No problem. Thanks for that question. That was a great question.
We have a question in the chat as well. They said, fascinating that so many different genetic variants can result in this recurrent behavioral phenotype. Final common neurological network pathways.
Question mark.
Thanks. So, are there any common neurological network pathways where all these things combine?
That's a good question. I would have to look more deeply into that. I would say that there's some functional imaging studies. We just don't have a definitive a definitive pathway. I'd say like for the same syndrome, yes, but for different syndromes, because the diversity of the symptoms, I mean, you'll see like some of them have like GI manifestations, some of them have very distinct like a seizure. Basically, almost all of them have seizures. It's not nothing that I could find that was like a simple common pathway. So I don't have one, but it's possible. I didn't see any major studies showing that they were similar ones, but there could be some out there, just not, I would have to look into it.
Any other questions? All right. Thank you so much, Dr. Smith.
Thank you. Feel free to send any questions to my email, and I can always look into things too, since I have some resources.
Okay.
All right.
Have a great day, everyone.
Thanks.